All right, so shoulder and shoulder girdle. I just do a quick review of the anatomy. This is mostly there as your reference. I'm not going to go over a ton of this, but most of us think of the shoulder joint as the glenohumeral joint, which is accurate, but there is more to the shoulder than just that joint. The acromioclavicular joint, where the acromion and the clavicle meet, and the glenohumeral joint, and then the sternoclavicular joint. But scapulothoracic joint is not a joint, but it is one of the most important parts of shoulder dysfunction. So I wanted to talk about that as it is an articulation. It's the movement of the scapula. Your scapula doesn't really have a bone connection to your back. It's all through muscles, but it does have upward and downward rotation, which makes it an articulation. And we call it a joint, but it's actually an articulation. And that's when we're going to get into the scapular stabilizers. When you understand how the scapular stabilizers can fail, then you start to understand why you might start having neck and head issues, neck and jaw issues, headaches, or, for instance, elbow, wrist issues. The anterior shoulder anatomy, the things that I would want to point out, just the fact that things like the pectoralis muscles are part of the shoulder girdle, as well as the lats, biceps, triceps. All of that is part of the shoulder girdle. And then I just give a little bit of the anatomy here, just in case you need a refresher, because we're going to talk about every single one of these muscles. Think about the trapezius as three different fiber directions, but one muscle and one innervation. The trapezius is one muscle, and it attaches on the back of the head, which is relevant to headaches. So it's also an extensor of the neck, so that's why the trapezius becomes relevant for the upper cross syndrome, the forward head placement, and neck pain. So the shoulder is really interesting in that it's connected to the spine all the way from the top to the bottom by different muscles. So you have the cervical part that's connected from the levator scapulae, which goes from the upper part of the scapula all the way up to C1. And then you've got the thoracic via trapezius rhomboids and the lats, and then the lumbar connection. You know, the lats connect via the thoracolumbar fascia all the way down into the sacrum for SI joint stabilization. So the lats are a shoulder girdle muscle that also affect the low back, and part of that posterior oblique sling that we'll talk about. I just did an episode about the lats because I feel like they get kind of short shrift a lot of times. They don't always cause pain, but they cause a lot of dysfunction. And if we forget that, it's easy to not treat the lats because, like I said, many times they're not causing your patient pain directly, but they definitely can be causing pain indirectly by inhibiting things like abduction and flexion of the shoulder. So the scapular stabilizers. We've got serratus anterior, which you're probably aware of. Many of you have studied with other people who teach motor points, and their shoulder assessment will be test all the deltoids, test the rotator cuff, and then test serratus anterior. And that's great. Serratus anterior is the dominant scapular stabilizer. It covers eight or nine ribs, depending on the person. But there's a whole lot more to scapular stability than just the serratus anterior. And pec minor is a very relevant cause of shoulder issues like shoulder impingement. It can entrap nerves, causing a thoracic outlet syndrome. It's a downward rotator. It depresses the shoulder, and it's prone to shortening, so it affects our posture. And then the rhomboid major and minor. If you think about muscle slings, the way the muscles work, the serratus anterior and the rhomboids create a sling. The rhomboids will retract the scapula, and the serratus anterior will protract the scapula. And this is why desk workers with their arms extended have a stretched rhomboid. Their rhomboids are being stretched, and the serratus is being put in a stretched and short, tight position. So you'll get locked long and tight with the serratus, but that's inhibiting the rhomboids, and eventually the rhomboids can start to inhibit the serratus. So you'll have this sling of inhibited and tight muscles. The trapezius is super important. The upper trapezius is what you're going to see causing a lot of pain for a lot of people. I don't know about you, but I feel like 20 to 30% of my patients on a daily basis are coming in because of neck upper trap pain. That's like so many people of every age. They come in and they'll put on their intake shoulder and neck pain, but what they really mean is levator and trap pain that affects the neck and the shoulder. And we're going to be, that's the dry needling that we'll be doing, and I know some of you will need it and will benefit greatly from having had it done. And levator scapulae is super important. It's prone to shortening, so that's where we get a lot of our neck pain patients. For me, the neck pain top two are going to be the semispinalis capitis in the back of the neck and the levator scapulae. Neck pain on like most people, it's those two, and occasionally if they've had whiplash or something, then there'll be the side lateral muscles that have also been impacted. But semispinalis capitis and levator scapulae are my go-to muscles on an initial neck treatment. If I'm trying to be really minimal with the needles because somebody's super nervous, they've never had acupuncture before, they're here for neck pain, that's what I'm going to treat first. It's 4 needles and up to 10 minutes, and I usually stand right next to them and make sure they're distracted. We'll talk about things just because they're nervous. And once the needles are out and they can feel how much better their neck feels, then they have more confidence that this is going to help them, and they're less nervous. So this is just for reference, but it's good to see all the attachments on the scapula for all these muscles. 17 muscles attached to the scapula. The scapula is the foundation of the shoulder girdle. It's the stabilizing platform for the upper extremity. It's like the roots of a tree for the upper extremity, being the trunk and the branches. So the scapula is really, really important. So the actions, this is just vocabulary, but protraction is when the shoulder goes forward, when the scapula goes forward. Retraction is pulling back. Elevation looks like a shrug. Depression is the opposite, pushing down. Upward and downward rotation. Upward rotation is when the scapula goes up on abduction or flexion, and then downward rotation is when the scapula goes down on extension and adduction. The scapular stabilizers contract together to stabilize the scapula against the ribs. It's primarily going to be your rhomboid and serratus anterior and the levator scapulae that all engage together to stabilize the scapula solidly against the rib cage. If you think about it, serratus anterior does upward rotation and protraction, and then rhomboid does downward rotation and retraction, so they're complete antagonists to each other. And then levator has to tighten to avoid too much upward rotation from serratus anterior. Levator is a downward rotator. So the two downward rotators, the levator and the rhomboid, engage to fight against upward rotation from the serratus, and thereby stabilizing the scapula solidly against your rib cage as a platform. And so when people have overuse injuries of the shoulder, the actual shoulder joint muscles, it's usually because of a lack of stability from those muscles that will cause an overuse injury, because when your scapula is not stabilized, your deltoids and your rotator cuff have to work harder to stabilize. And they're not meant to have to do that.